بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to welcome you here in the 33 sessions of the IMC Family Medicine Club, and I would like to welcome you all here. I'm sure that we have a good number of attendees online. More than 4,000 are registered, and we hope the scientific event will be quite informative and fruitful for all of you, inshallah. As we have promised you, we are always trying to select certain topics that is related to our day-to-day practice in family medicine. And today we decided to have a topic which is quite important for all of us as a family physician and general practitioners, which is antibiotics in community-acquired infections. As you know, ladies and gentlemen and colleagues, this is one of the very crucial decisions that we always make, whether to start antibiotic and not to start, and when to start, and what dose, and what selections of antibiotics we should use. And knowing that there is an increase in antimicrobial resistance, which is one of the big challenges that we encounter in our daily practice. And unfortunately, in spite of having this resistance, we don't have a new developed antibiotics to be added on top of what we have. So we are so limited with certain numbers of antibiotics. So that's why we have to be very meticulously selecting these medications appropriately according to the need. And we should have certain strategy to prescribe the antibiotics based on the type of infections and the type of organisms. And we have to understand that we have to use certain antibiotics which has a narrow spectrum of antimicrobial activities in order to safeguard the other antibiotics for the more serious infections. So today we are going to have three speakers who are going to be highlighting the issue of antibiotics in the community-acquired infections. And we are going to start by the first topic, which is going to be the quick reference guide to the community-acquired infections in primary care. We come across a lot of infections, and this type of infections will be summarized by our guest speaker, who is Dr. Saeed Al-Amoudi. Dr. Saeed Al-Amoudi is a consultant family medicine in the International Medical Center. He has joined IMC since 2020 in family medicine department, and he has his professional career and growth has been, went through different stages till he reached the level of consultancy with a full commitment to his position and educations and contribution to training as well as publications. So I would like to invite Dr. Saeed to be on the stage here to give us the topic, quick reference guidance to the common infections in primary care setup. Thank you, Dr. Saeed, for accepting the invitations, and I would like to leave the floor for you.
Thank you, Dr. Ashraf, and thank you, everyone. Actually, I am honored to be here today, and thank you for the invitation. Today, my presentation will be like a quick reference about the antimicrobial or the common infection in primary care. I think I need to be really quick to cover everything, and I hope First, these are my objective. We have a small introduction about the common infection in primary care, upper respiratory tract infection. I will talk about rhinosinusitis mainly, pharyngitis, otitis media, as they are the most common complaint that we are faced in the primary health care. Lower respiratory tract infection, and specifically community-acquired pneumonia. I will talk about the workup and treatment, gastroenteritis, causes and treatment, how to manage these cases, and also for urinary tract infection, we have the classification and the approach. So, for the introduction, I prefer to start with this study. The objective of this study, which is done in 2022 and published in the International Journal of Infectious Disease, it's about when to give the antibiotic and what is the complication that might occur. The study is done and shows the patient with upper respiratory tract, lower respiratory tract infection, and urinary tract infection. Some of them started on antibiotic, and some of them just observed for the culture results, and it shows that for the upper respiratory tract infection, the incidence of complication was very low. However, for the urinary tract infection, there were more severe complication in the 30 days period. So this gives us a hint how important selecting antibiotic and how to initiate the antibiotic at the right time. So I will start with the upper respiratory tract infection with the rhinosinusitis. As we know, we classified rhinosinusitis to acute, subacute, and chronic according to the duration. According to the duration, acute symptomatic rhinosinusitis is below 4 weeks, subacute from 4 to 12 weeks. More than 12 weeks, it's considered chronic. Why we said that? Because of the management and the symptoms. For the patient, usually they come with purulent nasal discharge, nasal obstruction, facial pain, or fullness. So most common etiology is viral. Just 0.5 to 2% of them are bacterial and need antibiotic. So how can we differentiate? What are the indicators? We have 3 indicators could help us in starting the antibiotic. First of all, the duration of symptoms, more than 10 days. I think they need to be started on antibiotic. From 3 to 4 days with severe symptom. When we said severe symptom, fever above 39, facial pain, purulent nasal discharge, and with bimodal illness, if there is a worsening of symptoms after initial improvement. So these indicators could help us to start the antibiotic and give us a hint this is a bacterial rhinosinusitis. We need to be careful because overdiagnosis and overuse of antibiotic could increase the resistance. Some meta-analysis shows that methicillin-resistant Staphylococcus aureus reach up to 15.9% resistant, and this is a huge number. Also, what about investigation? Radiological investigation or lab investigation like culture, sinus X-ray, sinus CT scan, MRI, ultrasound, when we can order that. For routine evaluation, no indication for that. We can use the indicators. These kept for the complicated cases with when sepsis or orbital cellulitis are suspected, we can use that. The treatment of viral sinusitis mainly supportive. We can use analgesic, normal saline irrigation, topical nasal steroid, topical decongestant, ipratropium bromide topical, and mucolytic have some benefit with some patients. What about the antihistamine? Actually, we need to keep in mind that antihistamine may cause over dryness and increase the discomfort of the patient. So it could help some patient and it could give worsening of symptoms for the others. The most important question, antibiotic treatment for bacterial rhinosinusitis. Treat with antibiotic or not? Okay, we can start the empiric antibiotic if moderate to severe pain and fever, if there is worsening or doesn't improve in after 7 days of observation, and in some cases like immune compromised patient. And these are the choices. Actually, there is many guidelines and there are many recommendations locally and nationally, but most of them prefer the amoxicillin for adult and amoxicillin for the pediatric. We can use also for the adult doxycycline 100 milligram per oral BIT as an alternative. What about the second line? Fluoroquinolones is a second line, but we should avoid the TMP, SMX, and third generation cephalosporin because of the resistance. The duration usually for adult from 5 to 7 days, and for pediatric from 10 to 14 days. And also here, just for the allergy, patient with severe anaphylaxis or severe type 1 allergy, we prefer to use the azithromycin macrolide. For the other sorts of allergy, just delayed reaction, we can use the cephalosporin. For chronic rhinosinusitis, it's the same, but I think we need to refer the patient for ENT for more evaluation would be more appropriate. The referral, complications, if there is any complications or if there any failure of treatment or no improvement after 10 days. Next topic of upper respiratory tract infection will be the pharyngitis. I will start with small introduction that one of the most common encounter in family physician visit all over the world, account 1 to 2% of all outpatient visit for adult and about 6% for the pediatric visit at the PHC. The majority of them are viral. From 15 to 30% in children will be group A beta hemolytic streptococcus, and 5 to 20% in adult. The highest incidence of rheumatic fever as a complication in children from 5 to 18 years. Less than 3 years are very rare to cause rheumatic fever. Also, family history play an important role as a complication for rheumatic fever, so we can ask about it in the history. As we know, the viral is the most common cause. After that comes the bacterial, and we could consider the chronic non-infectious causes like GERD, smoking, neoplasm vasculitis, and radiation changes. The transmission usually via droplet. The incubation period from 24 hours to 72 hours. For symptoms and signs, I think all are familiar with the symptoms and signs. I will not go through all of that, but the most important information is there is no single history or examination can we rely on for definitive diagnosis of streptococcus. Here is the nice table. Actually, it shows the sensitivity, specificity, positive predictive value, and negative predictive value. As shown, we cannot use one of them as an indicator, and that lead us to use some criteria like Centaur score or rapid antigen test if it's available in the primary care. For the throat culture, the most sensitivity and specificity, it reach 99 specificity. Rapid antigen tests also in most of the researches have the same sensitivity as the throat culture or near it. Negative result no longer need to confirmation by culture. And these are the sensitivity and specificity. As we said, it's around 90s for both tests. And also there is a clinical consideration to diagnosis for group A beta hemolytic streptococcal. The Centaur score can be used, throat culture, and rapid antigen test also. Here I will just talk briefly about the general prevention because it's very, very important in the primary health care, and especially for us as a family physicians. Avoiding close contact with infectious patient, wash hand frequently, avoid smoking, first or second hand smoker, manage a preventable cause like shared will give an improvement for the symptoms of the patient. The general measure also like salt, water, gargles. Some studies show that could cause relief of symptoms, especially the sore throat for the patient. Analgesics like acetaminophen, NSAID could also be used, lozenges, and hydration. These are general measures for all upper respiratory tract infection, viral and bacteria. So what about the antibiotic? Here, most of the guidelines suggest the penicillin. Some of them prefer to go with amoxiclav or erythromycin according to the resistance, but most of the guidelines prefer the penicillin 10 days or as an alternative include amoxicillin as a first line. Erythromycin for the penicillin allergy patient and cephalosporin also. There is, as we said, treatment failure with the penicillin with group A beta hemolytic streptococcus has been reported. Some experts advocated cephalosporin due to better eradication, especially for chronic carrier. Why we treat with antibiotic? Actually, there are three main reasons. First of them, the symptom relief, and it's about 16 hours just for more earlier for the symptom, shorten the symptom duration. The second thing is to prevent the complication. And here, the most important complication in children, the rheumatic fever, but keep in mind, antibiotic will not decrease the occurrence of post-streptococcal glomerulonephritis. And the third part also to reduce the communicability of this bacteria. The medication choice, actually these guidelines help us to choose the antibiotic, but we just need to keep in mind the cost, activity, and the compliance for the antibiotic in mind. Also, oral amoxicillin, as we said, it's an alternative. After that, if we have severe allergy, we can use the macrolide, cephalosporin for delayed allergic reaction. And here for the pediatric, the same penicillin, amoxiclav can be used. Macrolide for the group A beta hemolytic streptococcal, it's uncommon in children younger than 3 years of age. Treatment with appropriate antibiotic could help to prevent rheumatic fever, as we said, and we should, especially in pediatric, to consider the complications like peritonsillar abscess and retropharyngeal abscesses. When to refer also for the pharyngitis, actually most of the referral occurred for the tonsillectomy. So also the parents, we face it in the clinic, asking about tonsillectomy, when we can recommend for that. The first thing need to be documented. Documentation is very important for the number of group A beta hemolytic streptococcus per year. As we know, as we know, 7 or more per 1 year, or 5 or more per 2 years, or 3 or more per 3 years. These are the recommendation. Could refer the patient for tonsillectomy, and also if the patient is difficult to treat with many allergic reactions to antibiotics, we should also consider the referral. The last part of the upper respiratory tract infection will be acute otitis media. Actually is very common in children, very rare in adult. Reach about 50 to 85% in children have at least one episode in the first 3 years of life. 24% have had 3 or more episodes just in the first 3 years of life, which is very common. Here we have bacterial, viral, and sterile acute otitis media. For the bacterial, the most common organism here, we have streptococcal pneumonia, Haemophilus influenza, and Moraxilla catarrhalis are the most frequent pathogens. According to the researches and meta-analysis, it could reach 80% of a bacterial infection. And the viral infection, actually the most common cause, reaching up to 44 of acute otitis media. Sterile infection from 10 to 25 to 30%, which has no pathogens detected. What about the diagnosis? Again, we can use some elements that to help us with the diagnosis. Actually, otitis media need three main criteria: acute onset of symptoms of otalgia, and the presence of middle ear effusion, plus the sign of inflammation in the middle ear. So we have the onset and the severity of symptoms to choose the antibiotic. Keep in mind, for non-verbal child below 6 months, we can notice tugging or rubbing of the ear, poor eating, and irritability. To examine the tympanic membrane and diagnose of acute otitis media, if any. For in the examination, bulging and fullness of tympanic membrane, bullae of tympanic membrane, and acute purulent otorrhea behind the tympanic membrane could give us a hint. What about the erythema? If there is only the erythema in the tympanic membrane, the positive predictive value is as low as 15%. Why? It could occur with fever, with crying of the baby, with upper respiratory tract infection. So if there is only erythema without signs of bulging of tympanic membrane, diagnosis of acute otitis media shouldn't be considered and shouldn't be given any antibiotic. This picture show on the left side otitis media inflammation. On the right side, otitis media with effusion, which is common after the acute otitis media. Here, we need in the treatment to control the pain. Decongestant and antihistamine have not proven to help, but may relieve nasal congestion in older children and adults. But we should be careful about the increasing and the side effects of this medication. What about antibiotic? Several meta-analyses showed that 61% and in some researches up to 2/3 result without any antibiotic within 24 to 48 hours. So could we observe? Yes, for some patients. We can categorize these patients into 3 categories, or the pediatric into 3 categories. Below 6 months, they need to be started on antibiotic. From 6 months to 2 years, here we can start antibiotic in just 2 conditions. If it's severe, again with fever more than 39, or if there is bilateral involvement of acute otitis media. What about unilateral severe? Also can be given antibiotic. This is from 6 to 2 years. It's different from in the older child with 2 or more years. In this, antibiotic should be only given for severe symptoms, okay? And other than that, observation is the most appropriate option. When we choose the observation, we need 2 things. One, shared decision with the family. This is very important, especially the family, they find themselves need to do something for the child, need to give an antibiotic. So shared decision and education of the parents mainly is very, very helpful. And also we need to have an appropriate follow-up. We can also prescribe for the antibiotic for some patient to be just kept with the parents if they can get access for the primary care, or if they are traveling, or if the patient or the parents have the access to healthcare. I think observation will be better. Here are the doses and the choices for the acute otitis media. Amoxicillin can be started. Amoxical for the patient who treated in the previous month, or if there is a concurrent conjunctivitis, or for children below the age of 6 months. Taking prophylactic amoxicillin for recurrent acute otitis media no longer recommended by most of the guidelines actually. Penicillin allergy, non-type 1, cephalosporin should be considered. I put the doses also, and we should detect the patient who need oral or IV or IM antibiotics. Penicillin allergy with urticaria or anaphylaxis, then we go to the other class, which is macrolide. Not recommended the trimethoprim and sulfamethoxazole, levofloxacin because of the resistance. We need to monitor the patient for middle ear effusion. So if the patient has middle ear effusion, does that mean failure of treatment? Actually, no. 70% of them will have effusion after 2 weeks of the infection, and this percentage will decrease by time until 10% after 3 months. So follow-up recommended from 8 to 12 weeks for the patient with middle ear effusion before the referral. Only when certain circumstances need to be referred, if there is hearing or language or learning abnormalities, then we can refer for ventilation tube. For the adult, hearing loss more than 2 weeks, we can do the audiogram for them. 2 or more episodes in period of 6 months. Here, consider ENT referral to exclude or to rule out any malignancy. For recurrent chronic otitis media, also consider the referral for adult patients. What about the persistent acute otitis media? It's persistent if there is no improvement from 48 to 72 hours. Reassess and confirm. or switch to second-line antibiotic, which amoxicillin, cephalosporin, macrolide, and clindamycin. No antibiotic, as we said, for the recurrent acute otitis media, but we can minimize the risk factor by decreasing the exposure to cigarette smoke, pacifier and bottle feeding to be changed to the breastfeeding for the pediatric, daycare attendance for the respiratory hygiene measures. The admission for acute otitis media is for febrile infant age below 2 months is very appropriate because sometimes they need to be started on ceftriaxone and monitoring for 24 hours. So, for the third part of our presentation, the lower respiratory tract infection, as I said, I will talk mainly about the community-acquired pneumonia. Why community-acquired pneumonia? Because it's the leading cause of infection-related death in our practice. 20% of them require hospitalization. 60% of them are in the geriatric age group. The mortality rate usually below the 5%. 25% of them need hospitalization. 50% of them need ICU admission. Here is the diagnosis. Usually the cough is the most prominent or most dominant symptoms for community-acquired pneumonia. All of these could patient come with. For workup, chest X-ray needed for confirmation of clinical diagnosis. Lobar consolidation effusion suggests bacterial etiology usually. Interstitial infiltrate suggests viral etiology usually. What about sputum and gram stain? Only if good quality and rapidly processed, we can use that. It is not sensitive, but very specific. For blood culture, only if sepsis is suspected, positive in 5 to 14 of the cases. Usually, initial treatment is usually empiric. Influenza A and B rapid antigen should be considered, especially if there is an outbreak or in season. If failed outpatient treatment, consider the TB also. Intubated patient need to have endotracheal aspirate for culture. Here is the pathogens. The most common bacterial is Streptococcal pneumoniae from 20 to 40%. And for the pediatric patient from 4 months to 4 years, respiratory syncytial virus, the incidence peak in 2 to 7 months of age. For 5 to 18 years old, the mycoplasma pneumonia is the most common pathogen, and azithromycin are recommended, or any of the macrolide. For the CARB 65, this score can be used for the severity of pneumonia and need for admission and hospitalization. It includes confusion, uremia, respiratory rate, blood pressure, and age above 65. Point for each. CARB 65, if the score is of 0 or 1, can be treated as an outpatient. 2, 3, 4, or 5 need admission or ICU because it's considered it might be severe infection. For outpatient regimen, no comorbidity, no risk factor for MRSA or Pseudomonas, amoxicillin, doxycycline, and azithromycin are the first-line therapy. With comorbidities, we can use amoxicillin, cefodoxime, or cefuroxime, plus doxycycline or azithromycin. So we need combined therapy or monotherapy with fluoroquinolone according to the resistant and according to the sometimes to the infectious disease advice. For prevention, the same smoking cessation, but here we have the immunization is very, very important prevention. We can detect patient need immunization. Hygiene measure, mask and hand washing are also effective. For the pediatric, most common, as we said, viruses, and most common bacterial for preschool age, Streptococcal pneumoniae, Haemophilus influenza. So we need to use the amoxicillin as a first line. Second line will be azithro or clarithromycin. For the school age, mycoplasma pneumonia and chlamydia pneumoniae, azithromycin will be the appropriate choice. What about gastroenteritis? The goals of the gastroenteritis actually to replace the fluid and to identify the causative organism. For the diagnosis, history is very important, and also the lab. We need to do culture, ova and parasite, fecal blood and leukocytes for some patient to detect the organism and give the appropriate antibiotic. Oral rehydration therapy, actually it's recommended by the American Academy of Pediatrics to use the oral rehydration therapy for the pediatric. Even it's better than the diluted fruit juices. For the adult, sport drinks, diluted fruit juices, and watery soup could also we use it for the rehydration. Intravenous therapy should be considered for some patients. The dietary adjustment and devices like avoiding fat, boiled vegetable starch, soup, and yogurt. Patient usually asking when we can resume their normal diet. Actually, there is no specific duration. As soon as possible or as tolerated, we can return to the normal gradually. Common infection, as we know, rota, norovirus, Campylobacter, Salmonella, Shigella, for amoebiasis, Gardiasis, and Cryptosporidium. Pseudomembranous enterocolitis, traveler's diarrhea, and Vibrio cholera should be considered also. Viral gastroenteritis, the majority are viral, from 75 to 90% of acute gastroenteritis in developed country are viral. Norovirus is the most common for adult, and rotavirus for infant and children. It is easily transmissible and very contagious, so preventable measures should be considered. Hepatitis A infection with poor sanitation and transferred by fecal-oral route. The bacterial gastroenteritis usually the same for adult and children. Here in our region, Salmonella, Campylobacter, Shigella, and Escherichia coli in the outbreaks are the most common bacteria, accounting 10 to 15% of the acute gastroenteritis. Especially contaminated water and traveling history are very important to ask about. For the Campylobacter, most commonly occurred from contaminated food. Rarely, but very important to consider Guillain-Barré syndrome and reactive arthritis as complication. Diagnosis done by culture. Treatment spontaneous without antibiotic or using antibiotic if the culture is proven to have the infection and sensitive to the antibiotic. Fluoroquinolone usually have increased resistance, so we not use it for empiric therapy. The Shigella, the second one is fecal-oral spread. The principle is it affects on the colon mucosa, so patient may notice blood, mucus, tenesmus, also may have a fever or low volume diarrhea. Diagnosis by culture, self-limiting, treatment according to the culture and sensitivity, but usually azithromycin, TMP, quinolone fluids, and no vaccine for the Shigella. Salmonellosis, there is two types, non-typhoidal and typhoid. For non-typhoidal is self-limiting, usually come with vomiting, nausea, pain, diarrhea. The source is eggs and contaminated food. Pet reptiles, especially turtles, can cause the transmission of this bacteria. It's, as we said, clinically self-limited, can cause endocarditis, osteomyelitis, and mycotic aneurysm. For the typhoid, fecal-oral contamination, also it usually starts with constipation and rash in early stage. After that, become diarrhea and pain. Diagnosis by culture, so from stool or blood, treated with fluoroquinolone. There are also vaccine available, oral and injectable, for people who are traveling to endemic area for salmonellosis. E. coli occur in the large outbreak, diagnosed with culture, usually had no fever. The complication is hemolytic uremic syndrome. The source usually contaminated meat. Treatment supportive, usually no antibiotic indicated. Just keep the antibiotic for very severe cases with bloody persistent diarrhea, particularly in children and immune-compromised hosts. For the pediatrics, it's the same, but here don't give any anti-diarrhea for the pediatrics because the complication probiotic also have a benefit effect on them, resuming normal diet, as we said, as soon as tolerated as possible. We can use also anti-emetic and anti-motility. Anti-emetic for children above 6 months of age, anti-motility usually above 2 years of age, and adult below 65 to prevent dehydration and electrolyte losses. These are general advices for antibiotic. Can be empirically ordered in cases longer than 10 to 14 days, suspected gardiasis, or traveler diarrhea, or if there is a history of water contamination, should be considered in patients with febrile gastroenteritis, especially with bloody diarrhea or moderate to severe disease. Collecting stool culture is very important. In general, fluoroquinolone used in adult, TMP-SMX in children, and metronidazole for protozoal, but we need usually culture to start the antibiotic, and usually before initiating the antibiotic, if possible, it will be better. Referral for severe dehydrated or severely ill patient, a patient with comorbidity like immune suppression, prolonged or refractory illness, premature or underweight infant or pregnant patients. From complementary and alternative medicine, zinc and probiotics show some benefit. For the zinc, reduces the duration of illness in children with acute diarrhea, but the most frequent side effect was nausea and vomiting. Probiotic, specifically the lactobacillus, shown to have benefit for the symptoms. The last part of this presentation, the urinary tract infection. Actually, UTI usually to be uncomplicated or uncommon from 15 years to 50 years of age, especially in males. In male, newborn, infant, elderly men, UTI is considered complicated and usually associated with functional or structural mechanisms. UTI among women is extremely common, and up to 6% of females have at least one UTI in their lifetime. And this is usually, we consider it as a huge number. In male, should be considered associated symptoms like acute bacterial and chronic bacterial pyelonephritis, urethritis, and the prostate problem like prostate cancer and prostatitis, prostatic hyperplasia. In male, the diagnostic test usually the urine dipstick, urine culture. For urine dipstick, the indicator pyuria, bacteriuria, leukocyte stress, and nitrate level. For urine culture, it's usually done if there is severe symptoms or there is any complications. Post-first UTI, renal and bladder ultrasound for infant and young children should be considered. Be careful about the effect of antibiotic and phenazopyridine on the test because sometimes give negative or positive results. Blood culture not routine test only if sepsis is suspected for the male patients. The management, avoid the unnecessary catheterization first, replace the Foley catheter if the patient on it when starting the antibiotic, hydration and analgesia. The first line for uncomplicated, fluoroquinolone, trimethoprim. For the male patient, fosfomycin, neutrophenatoin, and beta-lactam do not achieve the reliable tissue concentration in the prostate, so we prefer the first line for fluoroquinolone and TMP-SMX. For complicated, recurrent, and second line based on culture and sensitivity usually. For urologic evaluation in male, infant, and men with recurrent febrile UTI, admission consideration can for not tolerated oral medication or acute renal failure or suspecting sepsis. Ongoing monitoring is needed for some patients with worsening or persistent symptoms. Usually encourage the fluids. For the geriatric, 5 to 10% of them above 65 years of men are asymptomatic, and if they are asymptomatic, no need for treatment with antibiotic. For the pediatric, as we said, specific diagnostic criteria and evaluation needed, and the obstruction like vesicular reflux should be assessed. Differential diagnosis. Now we will go to the urinary tract infection in females with their differential diagnosis to just keep in mind. And diagnostic tests like urine analysis, the same, and the culture can be used and help us if there is a query for the diagnosis. General measurement usually the same, but with a postmenopausal woman, consider vaginal estrogen for preventing recurrent UTI. Also, for uncomplicated UTI, the first line treatment here, we can use a neutrophenatoin, fosfomycin, TMP-SMX. The second line will be fluoroquinolone and beta-lactam. Recurrent UTI, consider short-term antibiotic, patient-initiated treatment, or post-coital prophylaxis, and this is usually done after the referral to the urologist. Referral and follow-up, recurrent complicated UTI, need to be seen by urologist. UTI in children, especially below 1 year of age, refer to pediatric urologist. For ongoing care and monitoring, as we said, for the first time, no follow-up needed if the first time UTI cured after 3 days of therapy. For pregnant women, monitoring every trimester is needed. Complications like pyelonephritis, sepsis, renal abscesses, and obstruction need to be adjusted. Inpatient for complicated UTI, others managed, inpatient is for complicated UTI, others managed as an outpatient. Alternative medicine, as we said, cranberry probiotic and methamine for prevention, not for the treatment of the UTI, and it could help many patients. These are special consideration, nothing new, as we said, for the geriatric asymptomatic should not be treated. Pediatric consideration, vesicular reflux, duplicating collecting system, and also diagnostic renal bladder ultrasound voiding cystourethrogram are needed. These are algorithms. We can use it to help us in the clinic. This is a summary of all what I said. And this is the approach for the pediatric, as we said, and this is the antibiotics with the doses. This was my presentation. Sorry to be long, and thank you so much.
Thank you so much, Dr. Saeed, for this very interesting, illustrative presentation highlighting the common infections in primary care with the modalities of treatment for each one of them. So it was quite interesting, quick review. So now, ladies and gentlemen, dear colleagues, we will move to the second speaker, Dr. Rajia Murad. She's a consultant otolaryngology and sleep surgery in my clinic in Jeddah. She has external affiliate ENT consultant at Dr. Sulaiman Faqih Hospital in Jeddah, assistant professor and lecturer of ENT at Faqih College of Medical Science, a member of the American Academy of Otolaryngology and Head and Neck Surgery, member of the American Academy of Sleep Medicine, and member of the Saudi Society of Otolaryngology. The presentation will be spotlight on antimicrobial resistance in Saudi Arabia and context of the community-acquired respiratory tract infection. This is another interesting subject, will be highlighted by Dr. Rajia, and we would like to thank you very much for being with us here tonight, and I would like to leave the floor for you, please. I would just like to notify our colleagues who are attending online. There are more than 2,000, I believe. So just put your questions in a Q&A box, so I'll be able to pick up those questions who are relevant to the topic and forward it to the speakers. Thank you so much.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على أشرف الأنبياء والمرسلين. Thank you so much for having me. يشرفني وجودي بين زملائي وأمام الحضور الكرام. Today our talk will be about spotlight on antimicrobial resistance in Saudi Arabia on the community-acquired respiratory tract infection. I will be presenting this paper that has been published in 2022 titled Country Data on AMR or Antimicrobial Resistance in Saudi Arabia in the context of community-acquired respiratory tract infections, links between antibiotic susceptibility, local and international antibiotic prescribing guidelines, access to medicine and clinical outcome. So the main aim is to realize that AMR is one of the biggest threats in global public health. The study reviewed the AMR situation in Saudi Arabia and initiatives addressing it. Since this area requiring more information, will provide a call to action to minimize further AMR rise and improve patient outcomes. AMR initiatives, antibiotic use, and prescribing in Saudi Arabia were identified using published information obtained from PubMed, Google Scholar, and other internet platforms. And this was the methodology of this paper. The availability of susceptibility data, in particular for the key community-acquired respiratory tract infection pathogens, namely Streptococcus pneumoniae and Haemophilus influenzae, was sought. National and international community-acquired pneumonia, acute otitis media, and acute bacterial rhinosinusitis antibiotic prescribing guidelines commonly used in Saudi Arabia were reviewed. Context was provided by local clinician insights. The WHA, or the World Health Assembly, formulated a global action plan for AMR in 2015. In response to that, a national action plan on combating AMR, or antimicrobial resistance, was published in 2017 in Saudi Arabia. The plan introduced a structured approach to the problem of AMR in Saudi Arabia in line with the WHO 5 objectives, which is summarized in number 1, to improve awareness and knowledge about AMR. The second objective was to strengthen the surveillance and research. Third objective was to reduce the incidence of infection. And the fourth objective was to optimize the use of antimicrobial agents. And the fifth objective is to ensure a lasting funding that guarantees the continuation of action plans. The plan recognized the need for an effective One Health approach, including coordination across different sectors, including human and veterinary medicine, agriculture, finance, environment, and consumers. The current Saudi Arabia National Action Plan status, as reported by the WHA for 2020 and 2022, shows that Saudi Arabia National Action Plan is being implemented and actively monitored through an evaluation framework. So this paper covered the aspect of antibiotic use and prescribing. Studies of the public from different areas of Saudi Arabia revealed poor knowledge and misuse of antibiotic. There was a large multi-area study done in 2016 with a number of participants, 1,700, which is a big number, in Saudi Arabia, showed 76.8% of respondents had recently used antibiotics, 71% taking antibiotics for colds, coughs, and 61% for diseases likely of viral origin. Most would use antibiotics without prescription, and there was a lack of public knowledge about the effects of overuse. Another study in Riyadh with participant numbers of 920 showed most participants were aware of potential adverse effects of antibiotics, but nearly 40% of them had taken non-prescription antibiotics in previous 6 months, mostly for influenza. A survey for healthcare providers, including pharmacists, doctors, identified the need of education about antimicrobial resistance, duration of treatment, unnecessary antibiotic use, and use of broad-spectrum antibiotics were common. That included dentists as well, which revealed excessive and inappropriate antibiotic prescribing. And despite the informants in 2018 of a law prohibiting over-the-counter dispensing of antibiotics, there was no significant decrease in this practice. Another aspect of the paper covering antibiotic susceptibility surveillance, it talked about global surveillance studies. Mainly we'll focus about SOAR study, SOAR standing for Survey of Antibiotic Resistance, which is a multinational antibiotic surveillance study running in a range of countries, including Saudi Arabia. The study has been running since 2002. If you're interested to know about SOR, you can find it easily online, and you can also search for another similar study studying susceptibility of other antibiotics like ATLAS, GLASS, surveillance, which until 2021, 107 countries participating in GLASS surveillance. So focusing on SOR study, which is still running in Saudi Arabia, collects and makes available in published paper antibiotic susceptibility data for two most common pathogens causing community-acquired respiratory tract infections, namely streptococcal pneumonia and Haemophilus influenzae. Identification and susceptibility testing are performed in an independent, centralized laboratory using standardized methodology, CLSI, allowing for comparison to be made. Data is analyzed based on 3 different breakpoints: CLSI, UCAST, dose-specific, and pharmacokinetic and pharmacodynamics breakpoints. So this slide shows the result of susceptibility of CLSI breakpoints for antibiotics against streptococcal pneumonia, collected as part of SOR studies in Saudi Arabia between the year 2015 and 17. You can see the comparison between penicillins, cephalosporins, macrolides, and fluoroquinolones. As you can see, the susceptibility of amoxicillin is almost 89% compared to ceftriaxone, the broad-spectrum cephalosporin, and levo and moxifloxacin and their fluoroquinolones, and compare it to the cephalosporins like cefuroxime and cefaclor, and the azithromycin and their macrolides. So you can see the difference in susceptibility against streptococcal pneumonia in common community-acquired respiratory tract infections. This slide shows the susceptibility for antibiotics against Haemophilus influenzae isolates, collected as part of SOR studies in Saudi Arabia, again in the same year. Here we can see the susceptibility against amoxiclav, 100%, and you can see the other classes as well. So the SOR data from Saudi Arabia, in summary, streptococcal pneumonia isolate, 88.9% of the isolates were susceptible to amoxicillin and amoxicillin clav, but this fell to 52.8% for the macrolides, erythromycin, azithromycin, and clarithromycin. So please keep this in mind whenever you diagnose and try to prescribe the appropriate antibiotic for the patient. Try always to refer to the local data for susceptibility to avoid unnecessary prescription of antibiotics or delay in managing the patient when prescribing a weak antibiotic or already not susceptible for a certain antibiotics. For the fluoroquinolones regarding streptococcal pneumonia and levofloxacin and moxifloxacin, streptopneumonia susceptibility was 100%. For the Haemophilus influenzae, high susceptibility to amoxiclav acid, cefpodoxime, and ceftriaxone, like 100% was seen, while susceptibility to ampicillin was only 87.3%. The majority of isolates were susceptible to macrolides. All isolates of Haemophilus influenzae from Saudi Arabia were beta-lactamase negative. Within this population, 2 were BLNR according to CLSI breakpoints. The paper also covered the examples of the guidelines referred to by physicians in Saudi Arabia for community-acquired respiratory tract infection management. The guidelines split into local and international prescribing guidelines. These are some examples, local guidelines like Antimicrobial Stewardship Subcommittee of the National Antimicrobial Resistance, General Administration of Pharmaceutical Care at Ministry of Health. And some example of the international antibiotics, as you can see, the IDSA in 2007, 2011, and the appropriate antibiotic prescription 2013, the American Academy of Pediatric, and the Infectious Disease Society of America. So those were the references where practitioners in Saudi Arabia usually refer to, according to this paper. Antibiotic availability in Saudi Arabia, it has been mentioned that substandard, poor quality, or falsified antibiotics promote antimicrobial resistance and the spread of drug-resistant infection. Since poor quality antibiotics are unlikely to contain a full dose needed to eliminate all the infection pathogens, this would encourage resistance to develop and allow resistant strains to survive and to be transmitted. And the most recent summary from the WHO Global Surveillance and Monitoring System, GSMS, for substandard and falsified products reported substandard and falsified medicines in many member states. However, Saudi Arabia was not included. So always keep in mind which manufacturer to use, trusted manufacturers with standard quality control to ensure the appropriate antibiotic given to the patient and to avoid antimicrobial resistance. Local insights from a clinician expert comment. Recent decades have seen antibiotics overused by physicians. Prescribing antibiotics for bacterial infection is challenging and requiring detailed infection and antibiotic knowledge. In Saudi Arabia, there are multiple endeavors to establish treatment guidelines to advise physicians in terms of managing infections and prescribing. Bacterial AMR burden is recognized worldwide. Global organizations have published guidelines for safe practice and use of antibiotics. Appropriate management and infection should reference the local hospital's antibiogram, since there may be difference between international, national, and local guidelines. Success in antimicrobial stewardship program in Saudi Arabia is based on recognition of the problem of antimicrobial resistance and facing the reality of antibiotic over-prescription by healthcare providers. So in summary, the take-home message is to realize that antimicrobial resistance is one of the biggest threats to global public health. And Saudi Arabia is active in developing initiatives to address AMR. Saudi Arabia has an increasing AMR and that is exacerbated by antibiotics use without prescription. Healthcare professionals use a range of international and some local antibiotic prescribing guidelines for community-acquired respiratory tract infection. Surveillance of AMR in locally prevalent microorganisms is limited. So another take-home message is to try to participate by any means as healthcare providers, as leaders in health sectors, to help in improving surveillance and research and increase awareness between healthcare providers to refer to the local guidelines for antimicrobial use. I encourage all of you to refer to SOAR surveillance, to dig in more and be more aware about the susceptibility of antimicrobials and organisms. A more standardized and inclusive approach in developing local guidelines using up-to-date local surveillance data could make management guidelines use more locally relevant. for clinicians, paving the way for a higher level of appropriate antibiotic prescription and improved surveillance. Appropriate antibiotic prescription would in turn limit antimicrobial resistance development and improve clinical outcomes for patients. Thank you very much for having me. Assalamu alaikum.
Thank you so much, Dr. Raji, for this presentation that put a spotlight on the antimicrobial resistance in Saudi Arabia. And now we are going to end our session by having a very important topic that is related to the updating antibiotic guidance, choices of common infections in primary care. And this will be delivered by our guest speaker, Dr. Nizar Bahabri. He's a consultant of internal medicine and infectious disease, and he's in the International Medical Center, director of the Saudi Society of Infectious Disease and Microbiology of Mecca Province. He was the chief medical officer in Samir Abbas Hospital, Dr. Suleiman Faqih Hospital. He had many academic and scientific administrative positions. He's well known in the medical society as a medical social influencer trying to disseminate the right and evidence-based proved informations. So we are very pleased to have you here, Dr. Nizar, and I would like to welcome you here on the stage. So please, the floor is yours.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. رب اشرح لي صدري ويسر أمري واحلل عقدة من لساني يفقهوا قولي. Really, I would like to thank the organizing committee for their invitation, and I would like to thank God, alhamdulillah, إني قدرت أوصل. It was a challenge. Anyway, inshallah, I will be up to the point. I believe a lot of consultants before me have spoke about a very important topics about common infections, and you can say that I'm going to be the one who is going to test your knowledge now. So just be ready. So let's go for the first case, please. Yalla, will depend on what you learned. Next slide, please. Right. This is a 33 years old female who is having urinary urgency, frequency, dysuria, 2 days with no fever, nausea, or vomiting, and she have a few UTIs in the past few years, no drug allergies. What is your next step? Nothing? Do nothing? Symptoms will likely resolve by their own. Send the urine dipstick before antibiotics. Send the urine analysis and the urine culture before antibiotics. Start Bactrim, trimethoprim sulfa, or start ciprofloxacin. Yalla, who will go for A? No one? Who will go with B? Come on, no one? No one will go for C? All of us. All of you? C? Send the urine analysis and culture. Who is going to go with D? D you didn't like. Type E. Who will for sure say E? No, no E. Why no E? Cipro is a good antibiotic. Very good antibiotic. Huh? High resistant rate? Can it induce resistant? Okay, so,
doesn't fit with bacterial urinary tract infection to start antibiotic.
طيب, so Cipro. Cipro is a good antibiotic.
But if the symptoms are fit for bacterial urinary tract infection, this presentation, I don't think.
Why? Symptomatic bacteria. You don't agree? طيب, Dr. Amir, do you agree?
No.
No Cipro?
No.
Bactrim?
No.
No Bactrim, no Cipro? You will just take the urine analysis and culture and what? Tell her go home? Huh?
We will select the antibiotics based on.
But she is having symptoms. So a lot of people will doubt that you can't. In reality, patients will come and will tell you, I need treatment. She is symptomatic. And in the guidelines, Bactrim is without a urine analysis and culture. It is in the guidelines to be first choice for symptomatic bacteria, the symptomatic cystitis. It is there in the guidelines. Bactrim is well known, and it is there. So let's go for the next slide, please. So just to refresh everyone, I know that the previous speakers, maybe we were speaking about it. Just there was a change a little bit in the guidelines. I will speak about it. طيب هي شفت كده دحين هي كلها تخميسات هذه دحين. لكن anyway, تعرفوا there was a lot of talk about complicated UTI. It included men and it included pregnant women. Now there are a lot of recommendations that men are out of complicated. Men are going to uncomplicated UTI. So not every man needs to be treated as complicated. And then only pregnant women continue to be so. Other than that, you can treat all as uncomplicated. Next slide, please. So we can say acute simple cystitis and acute complicated UTI, the one that have symptoms in it, fever, and will have chills, flank pain, and a lot of other things. Let's go for the next slide, please. So this is what I wanted to say. So this was a very nice article published in 2002, comparing females who you will treat or you will not give anything. She is symptomatic and you will just tell her, drink water. There was no differences between getting into complicated UTI, and even there is no difference in getting any further complication or resistance. The only thing, they got more resistant over the period of time. So there is a very good recommendation if your wife or your mother said that she had cystitis, you give what? Nothing. You don't do your urine analysis, you don't do urine culture, you do nothing. Love, support, hugs, water. This is what every woman should learn, that cystitis is a very common thing that they can have, and their treatment should be water. So this is maybe for a lot of you thing that you will not do. But if you had a female that you can convince that she should not get any antibiotic, really, it works. Can you ask me, do I do it? I totally do it. Does it work? If they trust you, it works. In my clinic, I will have a lot of females whom I can tell them, wait, don't take anything. And for reassurance, I will give them a prescription. I will say, do not dispense it. Drink a lot of water. Let's wait. See if your symptoms will get worse. So they want their security. She wants not to come back to wait in the clinic not to come back to it in the queue, but I will tell her, because I care about you so much, keep the prescription, do not dispense it, wait for 48 hours, drink a lot of fluids. If it goes away, do not take antibiotics. I will tell you, wallahi, it can work 50-50. I cannot tell you 100%, but it works 50-50. For a lot of females, they do not like the antibiotic idea. They were tired of the antibiotic idea. But please, very important issue to remind females about getting a good history from them for UTI or burning micturition. Just to remind everyone, please, that number one cause of resistant UTI and resistant bugs, like the nice lady sitting in the table, you will get UTI. Number one resistant cause is you will go to a physician who will give you antibiotic. Number two is if you were prescribed fluoroquinolones. So Cipro or Levo is number two inducer for ESBL. So I always like to remind everyone, if you have recurrent UTI, you are more likely to develop ESBL if you take Levo, and this will expedite things that you will never have any oral antibiotic. Then you will go IV, then shortly you will have nothing to give you, and then out of being simple cystitis to recurrent severe UTI because of misuse of antibiotics frequently. So number one rule, no antibiotic. Number two rule, drink a lot of fluid. Number three rule, go to the bathroom. Go to the bathroom. So a lot of nurses, females, they do not go to the bathroom. And it shows because they have some misconception about getting infected, or they do not like the urine of the previous one before them. And there is no attachment between your thigh. Just to remind all of you, there is no relationship between your thighs and UTI. You are sitting on your thighs. So it shows that, evidence shows, if you do not go for 4 hours for a bathroom, you have a higher chance of getting UTI. So number one, fluid. Number two, do not give Cipro. Number three, go to the bathroom. Drink a lot of fluid. Number four, very important, is physicians have to ask if this is acute, this is frequent, and it should be progressive and short. No UTI should tell you, a female will tell you, I have burning micturition since 2 months. Impossible. E. coli should come out of your ear if you have UTI for 2 months. It is impossible. It should be short. Most likely it will be atrophic vaginitis. It's your problem with hormones. It goes with progesterone cream. Family physicians all around who is listening to me, please remember, you are family physician. Listen to the history very well. Do not give antibiotics. Burning micturition for 2 months is never UTI. Never, ever UTI. It is atrophic vaginitis. Progesterone cream. No culture, no urine analysis. Nothing. Number 5 is you have to ask if a female is having pain during intercourse, because this will never be UTI, it will be inappropriate sexual intercourse. So physicians do not ask. Female come again with UTI, UTI, UTI. They never advise them for nothing, except they give them antibiotic. They never ask if she is having painful intercourse. In Saudi, if you ask me in my clinic, I am an infectious disease, so I'm not, I see less than others, but I see maybe more ESBL, more complicated. And if you ask me, out of 10 multi-drug resistant UTI that I see in a female, 11 will have painful intercourse. So nobody asks them ever about their relationship, and it will be the main source of their recurrent UTI. Number 7, you should never repeat the culture to see if the organism is gone. Never, ever. It will not go. It is colonization. Females, usually bladder is like a funnel. With keeping your urine not going to the bathroom, it becomes like a ball or an egg. In the bottom of it, there will be a remnant of urine. This will always have an organism. So it's not fun to ask your nurse, what is in the urine analysis? If there is bacteria? Yeah, there will be bacteria forever. There will be bacteria. You should ask her if there is a lot of leukocyte. Because if there is only bacteria with minimal leukocyte, that means that this is colonization. Look for another cause for hair burning maturation. You should never, never, ever give an antibiotic to a female with low white blood cells in the urine analysis, or minimal white blood cells in urine dipstick, except if she is pregnant in the first 36 weeks. Other than that, never treat a urine with bacteria without a lot of leukocyte count, because that means that it is a colonization, and you should never kill people in their homes. This is her friend. Look for another cause for hair burning maturation. So if we had patients with a urinary tract infection, then, can we go to the next slide? Then we will speak about a couple of ones, as I'm sure it was alluded before, but really evidence shows that it is unnecessary to do a urinary tract infection. You do anything related to culture unless you have complicated or you are worried about multi-drug resistant. Next. So always remember, testing had its pitfalls, but you should always try to protect rather than to do urine analysis and culture. Next, please. The ones that there are a lot of evidence for doing a urine culture is whenever the female have multi-drug resistant organism. Next, please. The treatment, as you all know, please, I want you to keep those 3: Bactrim, nitrofurantoin, fosfomycin. Bactrim, nitrofurantoin, fosfomycin. Bactrim, nitrofurantoin, fosfomycin. Fosfomycin is amazing. It will be 1 sachet over 1 cup of water, once a day, once every other day for 3 days, and it's gone, even if it's an ESBL E. coli. So you should never rush to other things. It should be fosfomycin, then nitrofurantoin. Remember, fosfomycin do not cover Klebsiella. It is great for E. coli, which will account for 75% of the organism. Then you go for Bactrim, and this is well known to go without urine analysis and culture. But remember, please, first step, try to prevent. Let her drink water. no antibiotics. Next, as I said, fosfomycin is really a great antibiotic. I've used it so much. Can it be used for ESBL? As I said, yes. Next. Another one is single dose gentamicin. Dr. Amir, have you ever tried this? It's amazing. So single dose gentamicin, it have a lot of evidence with a good renal function. You ask your patient, go get it from the pharmacy, one shot, intramuscular, done for all gram-negatives, including ESBL. There is a very good evidence for systematic reviews, multiple studies that shows very good effect. People are worried about side effect. It is not associated with single dose. This renal function, renal failure, you can save females from going for ESBL, ertapenem for 5 days and 7 days by a single dose, gentamicin, IM. It's all done. Those are, remember, your tricks for keeping your usual beta-lactam not to be used unless you really need them. Try to minimize resistance. Remember, back and forth, repeating it a lot. No Cipro, no Levo, unless you want to kill the patient fast. So the patient you hate, give them Levo and Cipro, so they can develop resistance fast and you get rid of them fast. Okay? Very good. Next, please. So as you know, for complicated, you have a lot of alternatives, but this is when you have complicated, this is when you use Cipro and Levo. You can use Bactrim, amoxicillin calvulinic acid, a lot of ones. And next, please. Remember, for ESBL, then it's ertapenem is your drug of choice. Next, please. Recurrent UTI, please, 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 all of the ones I have said, water, water, water. Go to the bathroom. You tell your patient, go to the bathroom every 3 to 4 hours, even if you do not feel you want to urinate, because she will never feel she wants to urinate. She have a bladder that can accumulate a half a liter of urine. Some of the females, there is evidence that they have bladders like a balloon. If you go to the cinema, always remember, the male queue is very short. The female queue is very long because they take long time in the bathroom. Half an hour cleaning, then a huge bladder. Men only have like 205, 250, 260 cc. As soon as he said, he will finish. Very easy, simple creatures. Men are very simple creatures. They can urinate anywhere. They do not develop UTI because they behave well. Okay, they are fast. This is why, because they have huge bladders. Please prevent reinfection, water and going to the bathroom. Make sure that she doesn't have atrophic vaginitis. Make sure that she doesn't have painful intercourse. Next, please. Next. Okay, next. Next, I will not go into asymptomatic bacteria because the simple answer do not give anything, except in a pregnant female. Next. Okay, so we'll speak about another thing. So this is a 52 years old male who presents with several days of cough, sputum production, chest radiograph shows pneumonia. He is negative for PCR for COVID. What is your following next step? Obtain a sputum gram stain and culture. And I'm sure a lot of people who said if the UTI it wasn't the right answer, this shouldn't be the right answer. Obtain precalcitonin prior to starting antibiotics. Treat with amoxicillin calvulinic acid or doxy. Treat with adestro. and treat with levofloxacin. Which one who will nominate for azithro? 14 days. Impossible. خلاص? 14 out. Treat levo 10 days with prednisolone. Out. Amoxicillin calvolinic acid and doxy. Yes, صح? So doxy is for atypical or amoxicillin calvolinic for the stripped. Optinium precalcitonin is never right, except if he is septic patient. And gram stain and culture, there is a very low evidence now for it. Next, please. I'm just gonna go, please remember, sputum and culture are no advice for an outpatient. No advice for sputum. I love people coming from the community taking sputum culture. I don't know what do they do with it, and it's always negative. Legionella, you can't diagnose it with sputum culture. Next, please. So remember, since 2019, the guideline states no sputum culture. You have to treat with the narrowest spectrum and for the shortest period of time. 5 days now have very good evidence for pneumonia. Therefore, usually in North America and Europe, doxycycline is an amazing antibiotic for pneumonia. صح? Here we say we cannot use it because we are worried about they tell you photosensitivity from being under the sun. Although we have a chronic vitamin D deficiency because we are not under the sun. We do not walk under the sun. We are one of the lowest maybe countries in the world to be under the sun. You see, even our lectures are until 11 p.m. It can't be any worse. We are a night people. We are not under the sun. So do you remember people will use, they will tell you, they will either use azithromycin or clarithromycin. I'll tell you my always joke. Doctora في ENT, I always say an ENT physician who gives clarithromycin, he really hates the patient. So he is the patient who will keep on always nagging, asking for sick leave. You get him in, give him clarithromycin. If you like the guy, you give him azithromycin. Because clarithromycin will make abdominal upset, it's BID and will make you vomit. Azithromycin, you take it once a day, so it's for the people that you like. So whenever a nurse see a physician giving clarithromycin, this doctor, he just really does not like people. Okay, he like to punish them for their cough, for their pneumonia. And remember, please, pneumonia is mostly atypical, so please remember this to cover for atypical. Next, please. So next, please. I will go for the last slide so I can finish on time. Next, please. Just for the last disease I want to speak about. Next. Next. Do not forget about Dr. Amir, if he speak, I cannot speak about vaccination in a family medicine symposium because they are the godfather of vaccinations. Really, I admire them for their work. Next, please. Cellulitis. It's number 2 in the world to cause multi-drug resistant organism because physicians misuse antibiotic for cellulitis. They treat every red leg as cellulitis. And they will tell you there is bilateral cellulitis. There is no bilateral cellulitis. There is bilateral lymphedema. This is the treatment of it is Lasix. Lasix. So, cellulitis is an infection. It should be acute. It should be for 2 days. It should be painful. It will decrease. It will limit his mobilization. He cannot tell you, I have a red leg for 2 months. and it is cellulitis. It should come again out of his ears. The strep will come out of the ear for 2 months. Impossible. It should be acute, it should be painful, it should be limiting. So as I always like to tell people, whenever you think about cellulitis, ask him, if it's since 2 months, why did you come today? If he tells you it is red since 2 months, but in the past 2 days I cannot walk on it, it is painful, this is cellulitis. But if he tells you it's the same since 2 months, he's just bored and he wanted to renew his diabetes medication, and now he's telling you, I also have red legs. This is never cellulitis. This is something else. Okay? So please remember the differential for cellulitis or red leg. Number 1 is lymphedema. Number 2 is lymphedema. Number 3 is lymphedema. Number 4 is lymphedema. Number 5, it's related to dermatosclerosis from diabetes. Remember, it can be allergy. Here we believe a lot of creams, like people, I know it's not only Saudi, even people from the Philippines, they love creams. They love put cream, they love it. Creams is something. So some people, they will have allergy from cream, and the physician will never ask them. And then they will discharge the patient on Augmentin, and he will go home and continue the cream. And he will tell you it never became better because he's still using the same cream which caused allergy for him. And then the internal medicine will admit him and give him vancomycin. And then the family will continue inpatient cream again. And it will continue red because nobody asked him if you are putting a cream. So remember, not every leg. Simple recommendation for guidelines. Remember, if cellulitis is a clean base skin, red clean base, there is no cuts, there is no papules, there is no bullae, the causative organism should be stripped. Drug of choice is clindamycin. If the cellulitis have bullae on it or cuts, the most causative organism is staph, most likely MRSA. Drug of choice is Bactrim. Again, if it is a simple clean base skin, it's shiny, the most causative organism is stripped. Drug of choice is clindamycin. If it have bullae in it, then the most causative cause is MRSA. Drug of choice is Bactrim. If you ever remember those kind of recommendation, you will treat 70 to 80% of the people appropriately that come to your clinic. You will be remained with the 30 other female percent who are going to come with recurrent vaginitis, whom you are going to give them again antifungal suppositories, thinking that it's always candida, and it's never candida. You will always forget painful intercourse to be the causative cause of her recurrent vaginitis and recurrent candidiasis. Please, as a family physician, as a physician, you should listen well, try to prevent the recurrent outpatient infection, to decrease the use of antibiotics so we do not get into multi-drug resistant unless you really want to kill your patient fast. Thank you for listening. سبحانكم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك.
Thank you so much, Dr. Nizar, for these wonderful presentations that inspire all of us. So I would like to ask the speakers, please, to be on the stage here so we can start the Q&A session, please. Dr. Saeed, Dr. Rajiv. We will start by the audience here, and then we have a couple of questions from the online attendees. Yes, Dr. Abdul Hamid, تفضل.
Thank you, Dr. Ashraf. Thank you for our guest speakers for this session. My question to Dr. Rajia. Thank you. You mentioned one of the most important points to use the high potency antibiotic, not the low potency antibiotic. But now we are forced by the CCHI to prescribe a generic antibiotic, and the pharmacist will dispense the cheapest antibiotic, which for sure the quality is not as good as the full. How to solve this problem in the clinic?
I totally agree. We are limited by some regulations, as you said. But as a physician, sometimes, as you said, you don't have an option but to follow the patient and to check if the patient is not responding and then you're suspecting resistance, then you can take culture and you can report the medication to multiple sectors, report it, and then they will investigate. I'm sure you will have backup at this point.
I want just to add, I agree with her just because of really good experience. The problem of keeping ineffective antibiotics in the market is physicians. They do not report. What she said is report. Unfortunately, physicians, when they see it, they only complain to their colleagues about it. They do not report it. And this is the problem of keeping it in the market.
But what is the role of the Saudi FDA in this?
If you report well, if
Yeah.
you report, your pharmacist and you have a couple of physicians who will have documented MRN numbers, they are very aggressive.
Okay, very good. طيب, any questions, Dr. Hashim? Okay. Dr. Nizar, there is the use of prophylactic antibiotics and empirical antibiotics. What is the role of these two in our clinical practice as a family physician, different infections? And what is the impact of these in multi-drug resistant organisms?
Well, Wallahi, Dr. Amir, I think this is a great question. I will tell you, prophylactic antibiotic is there in the book.
Yes.
It's there in the recommendation. But to tell you the truth, if you are just going to take 5 minutes of your time to educate the patients, I will tell you, Wallah, I've had a very long years of dealing with those patients. Nobody speak to them about changing their behavior, about going to the bathroom, drinking water, and you will be amazed how much this can decrease it. I do not really give anyone prophylactic antibiotic. Maybe in the past 10 years, maybe I have given one patient because I really believe that this will induce multi-drug resistant. I always like to reassure my patient. I will tell them, this is not for, it's not the practice of everyone, but this is my practice.
Yes.
And I give them my phone number and they tell them, if you ever have it, now it's very easy. Talk to me. I need to make sure that you are dealing with it. Then I will give you fosfomycin. So I will give them fosfomycin for 1 day. Sometimes I will give them for 3 days and I will tell them take 1 day until it becomes resistant to fosfomycin. Then I will go to nitrofurantoin. I will treat them until it becomes resistant to nitrofurantoin. Then maybe 6 months it will be sensitive again to fosfomycin. So I never go to Bactrim until both are resistant. And then I will never go to Cipro until everything is resistant. So, but I will tell you really, teaching the females and listening to them, and wallah, it can do, even elderlies, I will tell them to drink water before they go and sleep. So they will wake up in the middle of the night, they will go to the bathroom.
That's a good idea.
Wallah, it's a life change.
Yeah. All right. Any other questions from the audience here? Regarding the national surveillance, Dr. Nizar, we don't have a surveillance. Surveillance, the national one. So
Wallah,
we don't
it's
know
very
exact-
sad.
Yeah.
Very sad.
So why?
Why it's, wallah, if you want me, it's It's a physician attitude, wallahi, Dr. Amir. It's very sad, and it's a physician attitude. You know, as a society, we tried with microbiologists and consultant infectious disease, at least for 6 years, consecutive, to just try to everyone to believing to collecting the data so we all can have sharing data. Nobody wanted. They will agree in front of the conference, and then nothing happens. Everyone wants to keep his own data for himself.
Okay.
لا والله it was much easier. احنا as a society we do have a budget, and you can do it. تعرف مين السوسايتي اللي عندهم a huge database يجمع فيها؟ لا قصدي مو مايكروبيولوجيست، لا في حقون الهيماتولوجي انكولوجي عندهم national database for everything that happens for kids. احنا we don't. Infectious disease and microbiology, they don't. Everyone want to keep his own microbiology for his own.
Okay, when to use broad spectrum antibiotics versus the conventional ones? For example, augmentin versus azithromycin, for example, for upper respiratory tract infection.
For upper respiratory, if you do not see patient who is really septic or he is having a clear-cut pneumonia, do not give antibiotics. Most likely it will be viral. يعني most likely it will be viral. Bronchitis, hoarseness of voice, never antibiotic, never. Runny noise, أنا تعرف دحين بس in some of the hospitals أيام ما كنت ماسك ENT جابوا لي الجنان. معلش sorry يعني. بس I close Cipro and Levo. I close Cipro and Levo for them. I did not allow them to prescribe it.
Okay.
Because they give for sore throat Levo. I have no clue with.
Yes. Okay, I think this was the last questions, and I would like just to conclude the session by thanking on your behalf, ladies and gentlemen, our guest speakers for the wonderful contribution, for the great success of tonight's discussions and the information quality that we have learned today from the clinical practice and the real world practice. It was really amazing for all of us. I would like to thank GSK for sponsoring the sessions, and I would like to also thank ملتقى الخبرات لتنظيم المعارض والمؤتمرات for organizing, and I would like to extend our thanks to our online attendees who were more than 2,000 attending with us. Thank you so much, and stay tuned with the 34th session of the IMC Family Medicine Club, inshallah, next month. Thank you so much. Have a wonderful night. يعطيكم العافية.
you.